this is a left revision tympanoplasty. In fact, which is interesting here is that I did myself the previous operation, and I did a special condition of Malleus-to-Stapedotomy procedure, but using a Malleus Replacement Prosthesis. This is a left ear, and there is another airborne gap. I put the MRP, the Malleus Replacement Prosthesis, plus a TORP from Malleus-to-Stapedotomy with a 7.5 millimeter long prosthesis. And now we can have a recurrent airborne gap following the previous operation, which was performed a few years before. And I think it's interesting to see what's happening with the MRP. So we'll discuss that together. So we have the left ear, and just to re-explain the position, this is 12 o'clock, 3 o'clock, 6 and 9 o'clock. So I will do the incision from here to here. You see probably here the position of the prosthesis with the cartilage into position here also. And the Malleus Replacement Prosthesis is inserted at 1 o'clock to this left ear. So I need to do a large incision, which is going to run from something like 11 here to 8 o'clock, something like that. So I will determine. I need to explore the position and the availability of the MRP, and what I think is that probably the TORP dislocated. Vous pouvez me le tenir comme ça, juste dans ce sens-là. Poussez comme ça. Là. Là? Ouais. Or short. Non. Comme ça. Là. Vers la gauche. Okay. Allez, décolleur. Alright, so I will now elevate the flap and see and explore the middle ear. To understand the cause of failure, of course, we'll probably have to change, of course, the TORP. We will decide. I know that the MRP is around there. Ciseaux. You see the cartilage still there? Okay. Décolleur. So I will now elevate inferiorly. I'm quite away from the position of the prosthesis, and it's a very large canal, which is not so good because in fact the speculum does not hold very well the skin and compress the skin, so the bleeding will be probably a little bit more than usual. Okay, now I'm going to go back at the superior part of the flap. You see now one of the hook of the Malleus prosthesis there, just starting to appear, and the second one is there. So I know I get my landmarks now. Calmez, s'il vous plaît. Interestingly, there's not much bony regrowth, a little bit, reducing a little bit the size of the hole which I drilled out, but not that much. So the mucosa is there. So this is the Malleus prosthesis, as you can see, still mobile, which is very interesting after several years. Calmez. Okay, so what my feeling is that the prosthesis is probably a little bit too short. The TORP, I mean, but could be also a dislocated prosthesis. The CT scan was not able to see exactly what's going on. You see the TORP here. We're going to see it in a minute. Alors, ok, table en avant, s'il vous plaît. Il y a combien de tension là, s'il vous plaît? Stop, c'est un petit peu trop. Allez, vous me le tenez devant? Oui, là, oui, voilà, comme ça. Un petit peu vers vous. Voilà, super. Cannet, manger marteau, s'il vous plaît. Okay, so the point is that I need to expose, of course, the ossiculoplasty entirely, meaning the position of the Malleus prosthesis plus the torp. There's a lot of adherence here. So you see, it's pretty good. I mean, if we have a nice condition here of the torp, which is still connected to the Malleus handle, so definitely there is no dislocation. And the beauty with this prosthesis is that there's flexibility and the fact that it's still very nicely mobile and connected nicely to the tympanic membrane, just like a regular Malleus, in fact. Okay, so of course what I need to do is to understand what's going on. I think it's too short. We have the distal tip, we have a nice exposure of the distal tip of this prosthesis. And so what I need to do here is to check the position. There is not much round window sign here when I push the prosthesis, which means that probably this is too short. So I need to remove this torp. So I will dislocate first the head of the torp from the Malleus, the titanium Malleus handle of the Malleus prosthesis right here, and now I can remove the torp. Pince, s'il vous plaît. Okay, I'm going to take out the torp like this, and again we have a nice condition of this Malleus handle, which is still vibrating nicely. You can see that it's flexible, connected to the tympanic membrane. We have a really nice condition here, and of course I don't have anything to do with the Malleus prosthesis now anymore. We have a new Malleus, which is fine. I'm going to use it again, trying to introduce a longer prosthesis, I guess, probably too short, but this is what I thought. 7.5 in this case was probably too short because we have a little bit of a lateralized tympanic membrane. You see how it's nicely connected and mobile. I'm going to look again to this. Very nicely mobile, flexible, so it's pretty good and stable. All right then. There's no Malleus, of course. The original Malleus was removed following previous surgeries. This patient was operated many times, I don't remember. Oh, many surgeries. But there's a long-term history of repeated surgeries. Okay, so we have this previous vein graft, which is now still there, as you can see, as usual. And now I'm going to measure first, but I will measure again later on. I will take a first measure from Malleus handle to over window right here, and definitely this was too short. I think we have a 5 to 8 millimeter long prosthesis, and you can see we are at the level of 8, which means I'm going to put at 8.5 millimeter long torque. But first, now I need to tête en déclive. I need to refenestrate the labyrinth, the over window. Stop. Because I cannot place the torp like this, because I'm going to use another vein graft. So I will drill out through the previous vein, just like if it was a foot plate. La fraise. Un œuf, s'il vous plaît. I'm going to use now the 0.7 millimeter diamond dusper as usual. I'm just draining out through the previous vein like this. And I think we can see now the fenestra. There we go. Of course, I don't want to suck into the labyrinth, so this is the reason why I take care of this. And that's fine. Now you can see the fenestra, which is fine. And I'm going to measure now the measurer, the distance right now to be sure about the length. Yeah, definitely 8.5 will be fine. Okay, so we're going to put a vein here, but I'm going to press the vein. The one I took was a little bit too thick, so I'm going to press it. I already put it on preparation, but this is a little bit too thick, especially because I'm going to use a torp, so and using the previous vein which was already there, so it's going to be too thick if I keep it like this. So I'm going to press it on a regular press like this, you see, and just going to wait for that, and it's going to be much better, I think. Comment? 8,50. So it's quite a long torp, but this is due to, of course, the history d'Andouze to this patient, repeated otitis, many surgeries before, lateralized tympanic membrane. But I think it was interesting to show you how it goes with the MRP following, I think it was 2 years before, which I did the previous operation. Alright, now the vein graft should be much better now. Un œuf, s'il vous plaît. Et historique. Here we go. That's the vein, which is much nicer. You see, translucent and very nice. So I'm going to take it now with the sucker, using the 0.9 millimeter diameter sucker. Okay. I'm going to introduce now the vein and stretch it over the fenestra. Attends, donnez-moi la plaque s'il vous plaît. I need to take it again. La plaque s'il vous plaît. It's not going nicely, so I need to take it in a different way. Okay. Okay, can be. Alright, so going to place now the vein, holding the vein with the sucker and trying to stretch it with the needle. And you see now it's much better. Rather than trying to rotate the vein, from the inside of the oval window, it's always better to remove the vein if it's not working and take it again from the outside. That's better now. You see it goes well. So definitely the previous prosthesis was too short, 7.5. I'm going to put a 8.5 now, millimeter long prosthesis. Non, celle-là. 8,7 ? Oui. Allez. Merci. So this is a special torp, much longer than usual. Then we have 6, 6, 7, 8, 8.5, so already fine. With a 0.4 millimeter diameter Teflon shaft. Now I need to introduce the shaft first within the fenestra over the vein graft, and then introduce the Malleus handle within the groove. So it goes nicely within the groove. And I can see already the movement in the round window with the light here, as you can see. So this sounds really good. And now I need to introduce the new Malleus handle within the groove. You see, this prosthesis, which I designed with Grace Medical, was fine because it's really adapting nicely both the Malleus relocation technique, but also this type of neo Malleus. No, ça va pas. So it's not working fine. It's not working fine. I'm not happy with this. Un œuf, s'il vous plaît. Okay, I need to take another vein because this one didn't work well. Okay, I will put another one. Allez, la veine, encore une veine, s'il vous plaît. Vas-y, je vais la préparer. I think probably remove the previous vein myself, so I need to put another one. Bistouri, s'il vous plaît. I'm not going to press it now because the fenestra is a little bit larger, so I think this is going to be fine. I'm going to use this one, this part of the vein. Alright, that's fine. Now I'm going to place it. Alright. Mesureur, s'il vous plaît. I need to measure again just to be sure about the length. Yeah, definitely it's 8.5. We are at the level of 8, which means 8.5. Okay. Inspiration encore, s'il vous plaît. Of course, what I need to do is to place the torp over the vein, which is not the case here at the level. Okay, it goes down now. Not yet. Changez-moi la spie, s'il vous plaît. I tried to find another sucker because it didn't work well. Okay, the shaft should go down there. That is good. So definitely 8.5 is a little bit too long. So I'm going to reduce that to 8. Allons-y. Donnez-moi la boîte s'il vous plaît. Je vais la réduire encore un peu. Ouais, je vais la réduire. Because 8.5 seems to be a little bit too long for me, so I'm going to reduce that to 8, removing 0.5. Okay. Okay, now it's fine. So I'm going to rotate the prosthesis in order to place the groove parallel to the Malleus handle. And I'm going now to introduce the groove within the Malleus handle within the groove. Crochets. I'm holding the prosthesis with the sucker and now trying to introduce the prosthesis within the groove. Allez-y, calmez. So let's see if it's going to work now. And now you see it's much better. Doesn't work well, doesn't stay in place. I don't know why. So I need to find a way to... Okay, now much better. I'm not totally happy with the feeling that I don't have a good feeling for that, so I'm not happy with it. Non, ça me plaît pas. Un 9 s'il vous plaît. I'm not happy with that. I need to find another way. Now I can see the movement of the light here, which is fine. And now you see the connection looks good. Yes, and now we have a nice round window sign. You can see the light on the round window here. And you see the movement of the light. So it's good. Okay, really good. So I'm going now to reposition the flap and check again to be sure that the final item stays in place. So, there's a new unit now. It's just like a single unit, you see? But there's something which is still pushing the prosthesis, which I think is this connective tissue. Ciseaux. Ciseaux. Cannelé. Some fibrous tissue here, but I think it looks good now. I would love to have this position, final position, staying vertical. I need to check again, but now it's fine. You see, it's connected and stable. So it's good. So I'm now going to reposition the flap and placing a merocell. Allez-y. Okay, great. So thank you very much for watching. I think it was interesting to show the evolution with time of the Malleus Replacement Prosthesis. Thanks very much and bye-bye.